Okay, good evening, participants. You're welcome to this Zoom session. It is exactly 8 p.m. and I'm humbled that we are 41. As we wait for more people to join this call, I want to appreciate that you have given us this time. Today's presentation will be introduced by the moderator, but I, as Benjamin, I want on behalf of BHF to say you're welcome. I'm the head of communications at BHF. And just a brief about Busoga From. It is an organization, it's an NGO located in Jinja, and we are working closely with the Ministry of Health, local governments, research organizations so that we improve health within the whole country. Our vision is to see health and thriving Busoga, and we want to achieve this through mobilizing and rallying professionals to use evidence to improve the health of children, youth, women, and men within this region. Our core program areas, we have reproductive, maternal, newborn, child, and adolescent health, malaria, HIV, and TB, regional planning and data use, infectious and non-communicable diseases, and that's where our session for today is. And then lastly, urban health. You can reach to us. Our website has a lot of information, our Twitter, then Facebook and YouTube. We are a membership organization, and through membership, we are able to bring to you such sessions. This Zoom is purely facilitated by the membership that people pay. So we invite you to become a member of Sogether From. As you see on the screen, individual membership is 100, institutions pay 500, and lifetime membership is 1 million. This to be able that we are able to support. At this time, I want to invite Dr. Yai, who is also of Sogether From, who is a moderator for today. Over to Dr. Yai Alfred.
Thank you very much, Mr. Benjamin, for that background to Busoga Health Forum. The National Incident Commander and colleagues at the Ministry of Health, members of Busoga Regional Emergency Operations Center, colleagues from across the Busoga region, our convener, Busoga Health Forum, and all the members of Busoga Health Forum. Ladies and gentlemen, I want to take this honor to introduce to you the topic for today's discussion. Today we are talking about Uganda's 2025 Sudan Ebola Virus Outbreak, the immediate response interventions in the country. And definitely we'll also say something about what's going on here in Busoga. I take the honor, first of all, to welcome all of you for this Zoom meeting, which is to enlighten us on the ongoing Ebola outbreak in Uganda and the immediate response interventions that have been done or that need to be done, so that all of us are on the same page and so that all of us can play our roles in various ways. I'm the hospital director based here in Jinja Regional Referral Hospital, and also where the regional EOC is. I see that many people are still joining. We have now about 80 something, but maybe I'll give a small background and later introduce our speaker for this evening, who is going to tell us much more about what's going on. But members, as you may be already aware, Uganda declared an outbreak of Sudan Ebola virus disease on the 30th of January, 2025. Benjamin, I hope I'm audible. I hope members, you are getting me clear.
Yes, we are clear.
All right. So on 30th of January 2025, Uganda declared an outbreak of Ebola, the Sudan Ebola virus disease. And I think members, you heard about the index case, which was a 32-year-old nurse at our National Referral Hospital in Mulago. Unfortunately, this index case had contacts in a number of areas, in Kampala, in Wakiso, in Mbale, and also we have some of the in-laws here this side of Jinja. And since then, a lot has been going on. because of these various contacts, we have had to do a lot of work to trace all these contacts and see how we can curb further spread. However, many questions have been asked by members of the public and health workers on what is being done, how many cases have been confirmed now, how is the response currently structured, and so on. And of course, to answer all these questions, we have a special guest that I will be introducing shortly. But as Busoga Regional Emergency Operations Center, we are working with the district, we are working with the Ginger City health team, but also other district health teams in the region to support surveillance efforts and also response interventions. We have evacuated a number of contacts to Mulago, but right now in Ginger Regional Referral Hospital, we are holding some cases pending investigation and of course their results for this season. And we do urge all our district health officers in the region to ensure that the district rapid response teams are active and surveillance efforts are strengthened, and also district task forces are activated. They meet regularly to deliberate on response interventions. But overall, we appreciate what the national EOC is doing to coordinate the rest of us and to lead the country to respond to this outbreak of this deadly viral disease, and to answer a number of these questions and enlighten us on these issues. I want to introduce our speaker, Colonel Dr. Henry Chobe Bosa, who is the National Incident Commander attached to the National EOC at the Ministry of Health headquarters. He is a public health specialist who is well known in this country. He has a vast experience in public health emergencies. He has led many public health response interventions in this country. A number of them, I think we remember. And we are blessed to have him as a country and also as a region, Busoga region, to this evening to speak to us about this current outbreak and what is being done nationally and how the response is being coordinated and structured for efficient utilization of resources. So, Dr. Henry, I want to welcome you now in the interest of time to speak to us, and members later, after he has spoken, we shall have a moment of Q&A. You can take note of any key issues that you may need to remark or ask. And as I said, at the end of his speech, we'll have a moment of discussion, Q&A.
Okay.
Yes, you're most welcome, Dr. Henry. If you're ready, I can let you come on stage.
Hello.
Members, I request that you get muted. If you're not speaking, please get muted, and we'll allow our main presenter to speak to us. Dr. Kano, Dr. Henry Chobe,
Yes.
the stage is now yours to speak to us. Thank you very much.
Can you hear me?
Yes, I can hear you well.
Yeah, good evening, Dr. Yaya, and good evening, colleagues. And thank you so much for keeping around to listen to us as we speak to this response. In the room where I am, I'm seated with the Director General of Health Services, and I would like to ask him to speak to you, if you permit, moderator, that he speaks to you, and then I can quickly pick it up.
Please, DG is most welcome to speak to us.
Okay, thank you,
moderators. Thank you, Dr. Yai, and thank you, the Busoga Health Forum, for convening this webinar and on a very important subject, and at this time when the country is going through its eighth outbreak of Ebola, but specifically it is third outbreak since it had of Ebola Sudan. And I think Yaya has highlighted the risks which definitely come, because Jinja and on Busoga definitely is mapped up as definitely those high risk areas. So what is key is definitely be able to share information. And this time normal outbreaks do start from communities, but this time we have had it start in a major hospital. Definitely we empathize with our colleagues who are now in quarantine, but I think definitely they are there to be able to protect them and their families, but also be able to pick up if they develop any symptoms, because we all know that when you not pick up symptoms earlier and you start management, then the outcome is. I know Chobe will definitely share with you so far what we have been able to do, what we know about the outbreak, what we have done, and probably where still we are looking at the gaps which we need to be able to close. But I think as Ginger, the Busoga region, we definitely, specifically speaking the health workers, that we need to embrace IPC, not only in the public facilities, but also in the private health facilities, that we need to emphasize IPC, and we need to be able to preach it and practice IPC. And also we need to be able to have the highest index of suspicion. If we get any case, sometimes we are so good so that if we know a person, even when he's sick, we are very close to it, it puts us at a risk. Definitely, because by nature of what we do, it becomes an occupational risk. I will not be able to speak to what Shobe is speaking, but I want to, that we as a ministry, we are coming up with an information pack, which we should be able to share at each of the health facilities. And we need to be able to empower communities. Definitely we empower communities to be able to protect themselves, but also if there are any case which they are able to identify, and be able to bring all these alerts so that we can be able to investigate them and close them, just like Dr. Yahi knows that we had the last 2 cases which all turned 3 cases from Jinja which turned negative. So I want to wish you a very good evening. Ask all the questions, and so that we leave no stone unturned. So ask every question, and I'm sure that Kano Chobe, with all his experience, is going to be able to answer. If there are those which he can't answer, he knows where the answers can be found. Thank you very much for listening.
You're welcome. Thank you so much, DG, for speaking to us. I think we'll now give the floor to Colonel Dr. Chobe Bosa.
Thank you, DG, and thank you, Dr. Yai, for the kind introduction and for the time again, once again, to listen to us, and at this time of the evening, more especially on a Friday. Colleagues, as we do know, and I think as DG said, we have to be on alert and at all times, so that we detect, we notify, and of course we have the individuals suspected managed appropriately, as I'll speak later in the course of discussion this evening. Rightly, as the DG said, this is not the first Ebola outbreak, and we have had many. And as it is turning out that Sudan Ebola virus, which is the cause of the current virus, appears to be predominant in Uganda more than any other country. That of all the Sudan Ebola viruses that have happened, most of them have happened in Uganda. The good news and the beauty we have is that they are controlled quickly, except the one of Guru, which was sustained and we had massive losses, as you see on the screen. And you see again before January 30th, when we notified the current outbreak, we had had these outbreaks in different areas. But not only this, we've had Bundibujo, Ebola virus in Bundibujo. We've not had that again here, but it has saturated again in DRC. So, colleagues, as I speak today, we will look at what we know so far, what the response is, and the message, and which to me or to us from this end, the message to the general population, the message to the health workers, and our colleagues, the quarantine individuals, part of which that DG has spoken to. So we know the individual that DG spoke about first developed symptoms around 19th, and he died on the 29th. And the 29th, on 30th, on the night of 29th, 30th, by 5 a.m., we had a sample run, and by 9, we had preliminary results. And by 12, we had confirmed from 2 laboratories, as I'll speak later. And then in 3 hours, we were able to notify the world. This was a record sequence of things. And of course, that speaks to the capacities that have been developed in this country, both in detection, but also in suspicion, and the speed at which we were able to do this. Thirdly, the index of suspicion among the health workers, which of course we really applaud that we were able to get this very fast and notifying so that we were able to launch the response mechanisms. Then subsequent activities took place, but we know the individual was, we think he was exposed between 29th through to January 7th thereabout, and we think when he developed symptoms on the 19th. And this, of course, we are looking at this to stretch back, as I will show in my next slide, to see the extent of potential transmission of this individual. The other thing that I need to speak to colleagues is that for the first time ever, we have an Ebola outbreak starting in the city or being detected in the city. And what you are trying to piece together here is to try as much as possible to identify the most proximal case from when we think, as I'll again show later in the presentation, of where the World Human interface was breached so that we have human transmission, which we see. So far as we speak of the 8 or the 9 cases we have, 8 of whom, as I'll speak again, show later, this is the individual, the one who died, and the subsequent cases. The good news, colleagues, is that all these individuals were identified from contacts. In other words, they don't have contacts of their own. Actually, they are contacts of the index case. The challenge we do have is, as what I spoke about earlier, that the potential cases that transmitted to him and the potential other lines of transmission have not been identified yet. And that's why I started at the beginning that we have to be on alert so that we are able to detect these individuals, get them in care, treat them and test them, and then treat them. And this is where our current investigations are targeting, and much of the response is targeting. We've tried to piece together a high resolution geoposition of the index case We know during that period that I've indicated above, where we think he was exposed, he was largely moving in Kampala. What we see the distribution here in Jinja through to Mbale, that is when he was moving to Mbale, where he moved. Between that time when he had symptoms on the 19th to 29th, when he died, he attended several hospitals, both in Kampala, Wakiso, and Mbale. And we do believe that he also visited a traditional birth attendant from Kampala through Jinja and then went to Mbale city. And of course, this shows you where this is seeing how he moved in this period. So we know then that he didn't move out of these areas in that period. And we think the exposure really must have happened in these areas. So looking at the facilities that he went through, some of them in Kampala, Mulago, and Wakiso, and then in Mbale before he died. We do know then since that he seeded contacts in several places, which I highlight here, from Kakumiro, Masaka, Wakiso, Kampala, Jinja, Budaka, Mbale, and Kapchora. The good news, colleagues, following this line of transmission, we have identified all these contacts, and they are being managed in institutional quarantine in different places that I'll show later. So currently, we have 2 clusters, an extended family cluster, largely wife, mother, child, householder, and also a facility, a health care facility cluster. And the middle whom you see is the case. So, of course, showing the timelines as they happened. And of course, currently, what are we doing? Again, as I said, we declared this outbreak in 3 hours of confirmation at both at CPHL laboratory and Uganda Virus Research Institute. Note that this was done as a means of cross-referencing, and immediately we activated both the national and the district level response mechanisms. We quickly undertook a risk assessment, which was informed by the likelihood of exposure, potential of amplification of the outbreak, and the context, specifically looking at vulnerability and acceptability of the current of the affected population and the potential impact on response structure and health services. So this landed us to the map that you see, where we have 3 categories. High risk category, very high risk. Those are the districts you see: Kampala, Wakiso, Jinja, and Mbale, and the Mbale city and the Mbale districts. And then the second tier category is where we have Kasese, Buikwe, Mayuge, Namutumba, Chibuku, Budaka, Luwero, Mpigi, Mitiana, Mukono, and Kakumiro, and then placed the rest of the country in moderate risk. Again, we've had coordination structures activated across through reactivation of same structures that we've been using. We've had the Honorable Minister leading a delegation to Mbale, where he attended the Joint City and District Task Force and conducted 2 live radio talk shows speaking to the population, and of course the 90-day plan being activated. In surveillance so far, the 9 pillars, sub-pillars have been activated. These vary: the POE, the case investigation, and the different pillars under surveillance, as we'll see. Here, we've reconstituted exit screening at Entebbe Airport. You bear with us. We'll be following you. It's going to be passive. You may not even notice it. It's only when you have symptoms that you'll be led and maybe led for second layer of screening and then seen. We've activated both passive and active case search. We have the toll-free numbers which are at Minimbari 0800 200 397. In Ginger, where we are, 0800 200 387. And here in the ministry, 0800 100066. And the toll-free SMS, which is 6767. When you log this information, we'll be able to get to you and, of course, take your alert. I'll repeat these numbers later in the discussion. For the facilities and the community, we do have a QR code, again, which I will show, which you scan and complete the information, and then that will be sent to us, and then we'll be able to activate the follow-up. We've activated mortality surveillance specifically for now all-cause mortality, except trauma, both in the community, but starting in the major facilities, and then these samples are tested at the different laboratories. In addition, we have community-based surveillance, and we've activated the quarantine sites in Kampala and in Mbale, where nearly all individuals' contacts have been are being monitored humanely. Here, where we have over 200 contacts coming from different areas that I've shown earlier, in Mbale, in Mulago, and of course in Ginger. Just to give you a visualization of the dashboard that imbibes the alerts as they come through from the QR code, which I'll show you later, and which we manage and verify and get the individuals taken on. So far, we've done genotyping of the index case, and it reveals a very close relationship between the Sudan Ebola virus of 2012 that was in Luwero, suggesting a shared origin with that virus and potentially pointing to a fresh zoonotic spillover event that we are dealing with. But of course, also to show that this rules out potential ongoing transmission among the survivors from the 2022 Ebola outbreak of Mubende. So again, of course, these pieces of work from both UVRI and CPHL that are consistent and mapping close to the Ebola outbreak of 2012 in Luwero. Case management, as I've said, we have 8 patients, 7 hospitalized in Mulago, 1 in Mbale. The good news, they are all in stable condition. And the reason why we think they are in a good condition, we are talking about day 3, day 4 of care. We don't know what will happen later, but we still see them stable. Usually by this time, they would have started having severe symptoms. But because of early detection from quarantine sites, we were able to get them, diagnose them early, and we started a standard care. Started on standard, apologies for the typos here, and on standard supportive care, and all of them have been managed with remdesivir. We have 2 treatment sites, an 84-bed capacity setup in Mulago, and a 6-bed setup so far in Mbale, and of course different individuals supporting the response. We have emergency medical teams deployed in different areas to support the response, and the psychosocial teams supporting the patients, quarantine individuals, and of course the community. Our diagnostic capacity, as I said, we have 2 central level static labs at CPHL Mbuya, Mwandegea, and the UVRI in Entebbe, supporting the response. But we've also detached a motorable mobile lab to Mbale, which of course does both RT-PCR diagnostics and the clinical support. And the aim of this is rapid processing of patients and to ensure we have a reduced turnaround time for patient care. Of course, with communication, we have retrieved, reviewed, and redeployed the materials used before, and of course, reoriented the health workers and the call centers. In the high-risk districts, we have mapped choose in these areas, and we started mass public awareness, and of course, engaging other groups, same way we are doing right now, and through different means. Permit me, colleagues, to speak a little bit about Ebola vaccines, and of course, looking at the landscape. Currently, there are 2 licensed vaccines for Ebola Zaire, and no, I want you to note this, there is no licensed vaccine for Ebola Sudan. The 2 for Ebola Zaire is a Everbo, which was licensed in 2019, and Zabdeno, that is usually called J&J vaccine. And of course, the one same that is used, and I will speak to this later, that if it's used, it can has cross protection for Ebola Sudan. Just to give you the bigger landscape of these vaccines and their advantages and the status of at different levels of development. The J&J vaccine, which part of which was deployed before the outbreak and deployed to some, of course, designed for Ebola Zaire, but the second dose given after 6 weeks, 8 to 6 weeks, studies show that it has cross protection for other viruses that include Ebola Sudan, Marburg, and Ebola typhi. So speaking about the candidate Ebola vaccines, the number of them that are different stages of development, but the frontliners are 3. One is RSV, and they are Chad3 Sabine vaccine and Chadox Sudan virus. Right now, under this outbreak, the RSV, the RVSV is the one that is currently under deployment, and it's a number of individuals have been vaccinated on this. And permit me to speak about this a little bit. It is based on the same recombinant vesicular stomatitis technology used for the other vaccine, the Ebola virus for Ebola Zaire. And the safety is supported by preclinical data and is highly rated to that virus, to that vaccine, to the Ebola vaccine. That has been approved for Zaire by WHO. And the design of the study is a randomized ring, or call it cluster, where it has 2 arms, the immediate and the delayed arms. The immediate, of course, the individuals are vaccinated within the first optimally, as early as possible, but at least within the first 4 days of exposure, and the delayed arm for those individuals that will be vaccinated after 21 days of exposure. It is a ring vaccine, but of course, a ring approach, but the analysis is at individual level. So just looking at the processes, when we have a confirmed case, speaking to this, then we engage the community before the trial, listing of the contact, these activities. This is done by Ministry of Health, then assessing the eligibility of contacts for the vaccine, and then closing that ring, meaning that you've identified all the individuals that you're going to vaccinate. Then randomization, which is either early or late, which is now or after 21 days, and we vaccinate and follow up only in the cause ring, and then follow at the different time points of follow up: 7 days, day 14, and day 21. So this trial was launched on 3rd Feb, 3 days after the declaration of the outbreak. Question is that why did it come that fast? You recall the last time when in 2022, much of the processes had been completed for this trial to be launched, and the outbreak ended earlier. So much of the processes, the earlier processes had been set. So that helped us to be able to kickstart this trial as fast as possible. Colleagues, as I wind up, what do we take away from here? Is we need to know the symptoms. We talk about high fever. We talk about headache, muscle aches, diarrhea, and vomiting. Latest in the stages of illness, you may have bleeding or bleeding manifestations. But usually it starts like a usual febrile illness with general aches. The GI symptoms come later. They may not start. So are the hemorrhagic manifestations coming later. So here we request the population to avoid close contact with symptomatic people and enhance hygiene as much as possible. And then thirdly, to report to facilities as early as possible. We need to have early presentation to care, which we think is good and spells to good clinical outcomes as we start to seeing that the individuals we have are actually doing well because we got them early. We think, whereas there is no licensed treatment, supportive care, and the trial drugs, we see them, we are having promising results. And that makes us think that we need to report for care as soon as one has symptoms. We also request you report anyone with symptoms or report the health facility with early signs or for early and use any of the Ministry of Health portals that I will demonstrate here. The QR code will publish this widely as possible so that you scan and fill this and have the information coming to us, generating the alerts that we see there. We'll verify them. If they are verifiable, then we'll go back and get these individuals into care. Again, as I said, use our toll-free lines, which are for Mbale 0800 200 397, Ginger 0800 200 387, MOH here 0800 100 066. Last time when I said 1000, I didn't get it, but the easier of getting it, and the toll-free SMS. Colleagues, the message from here is to request you to be calm. All is being done, and of course, we have a tested system that we are using, and we'll be able to control this outbreak in the shortest time possible, and we get out of this. But to only do this, we need cooperation, support, and consideration of each and every one of us, be it the population, be us the health workers at the different levels of care, or be it the patients themselves as they present to us. I thank you so much and hand over to you, Mr. Moderator.
Thank you very much, Dr. Henry, for that very elaborate presentation. You have answered a number of the issues, questions that said people are asking, or we are asking. And I thank you also for managing your time well. You have saved us some time for us to be, for you to be able to interact with the audience in this call. So members, I want to open up for any questions, comments, as guided by DG. Please ask as many questions as possible because this is the moment for us to get all the necessary information from the experts so that we are guided in the response. So if there's anybody asking a question, you can unmute and speak.
Thank you so much, Dr. Yai, our moderator, and approach the current speakers, the Director General and Dr. Chovi. I've looked at his presentation and I put emphasis on the first case. And my question is, I've not seen anywhere mentioning, neither any presentations I've seen about Ebola, the current outbreak. Have we been able to identify the source of the outbreak from the first case? Unlike other outbreaks, some of them were identified, maybe it was from the source got from animal from this site and so on. Is it possible? All has it been identified? Thank you.
All right, thank you for raising that question. Members, as you raise your question, kindly tell us who you are, and then you can go ahead. I think we can take a couple of questions, and then Dr. Henry will be able to respond to them later on. Anyone else with a question, you can unmute and speak.
Sorry, Dr. Yai, about that. I'm Dr. Oscar Melvin. I'm calling in from Central Kampala. Thank you.
Okay, thanks.
Hello.
Hello.
Hello. Yes, this is Dr. Kawanguzi. I'm calling from Bugolobi.
Yes.
Until the hemorrhagic signs begin, manifestation, most of the other signs and symptoms are non-specific. And there are some signs and symptoms that over 75% of outpatient visits might have, which makes it very difficult because these are the cases we see every day. So when it comes to high index of suspicion, I really, it becomes difficult until someone is having the dramatic signs and symptoms. I don't know what the incident commander might want to probably add on something to this. Thank you.
Thank you very much. I think that is noted.
Hello, good evening.
Good evening.
Yes, this is Dr. Rupert. I'm calling in from Kumi. I had Doctor talk about the vaccines. So I didn't really get it right whether this vaccine is now readily available at the vaccination sites or it is specifically at areas of high risk right now where the infection is. So I wanted some light about that. Thank you.
All right.
Hello.
Hello.
Thank you so much. So my name is Ronald Musoke. I'm a journalist. I work with the Independent magazine here in Kampala. I'm so glad I had to flock this presentation by the indefatigable Dr. Chobe. I just have a couple of questions. One is about the I think there was a point he raised on the index. Okay, the sequencing. I'm sorry, I'm not so much into science, but I'll try. You said that there's some sort of similarity as far as the current case when it comes to sequencing being quite similar to the one of Ruero. Could you just maybe share a little more about that? What does that exactly mean for me as a layperson? Secondly, with regards to the recent visit by the Minister of Health to Mbale, she addressed the press, I think, and then she made some statement which the press were not sort of happy with, where I think the press were trying to ask her to sort of give an update of the number of contacts, number of those who are infected, and she was like, that wasn't important at the time. That we would be briefed, I think, on a fortnight basis, and we found that odd. Some of my colleagues went out with the notion that maybe you are hiding information, and it will just shared a very elaborate presentation, which would be so good for the press. Maybe could you just clarify this? Are you sharing information with the press on a weekly basis or fortnightly basis? And why is this so? Because in the past you've been really good when it comes to sharing with the press. And if you just talked about the importance of cooperation, support, and coordination. Thank you so much.
All right, thank you. You can take 2 more comments or questions.
Hello.
Hello, please go on.
Yes, this is Dr. Mubarak, Yumbe Regional Referral Hospital. I want to thank the speakers for the very informative presentation. Two things. Maybe there was something that intrigued me, what DG shared about the information package. How soon are we getting that package so that we can be able to utilize it? Maybe to Dr. Chobe, I thank the ministry and the team for the response. However, are there opportunities of using other available maybe spaces, maybe WhatsApp, so that some of these informations can also be shared? We know that there are a number of young people and a number of community people who could get some of these messages if they are used, if we used some of those spaces. How soon are we also taking advantage of some of these spaces? Thank you very much.
Dr. Alfred, there are some hands. Maybe you could pick on them.
So this is Dr. Dan Atman from Proton. I just wanted to know, when it comes to Ebola is when it comes to Ebola from Sudan and Ebola from Zaire, we are a little bit near. I wanted to know from the doctor, my colleague, what are the chances of Ebola Zaire to attack the western part of Uganda? That is the Rwenzori region. Thank you.
Yes. This is Dr. Rubega. I'm in Uganda. Hope and Healing Center is my facility. So my question, so we see that the early stages of disease have a lot of differentials that it can give us, especially malaria, typhoid, and other infectious diseases, which are common in our region. So I would want to know, for a private facility, what would you recommend that we need to put in place to prevent the transmission of this infection if it's there in our community? Maybe if it comes to the chlorine, the sanitizer, is it really effective in killing it? The sanitizers that are on the market, if we need to prepare our chlorine to disinfect the patient's seats or the beds, what percentage do you recommend? Basically, give us some information on that. Thank you so much.
So maybe we can have Daniel.
Yes, thank you so much, Dr. Chobe and your team for the wonderful work that you are doing to protect the country. My question is about pregnant. I'm Dr. Kama Daniel, Kawempe National Referral Hospital. My question is about the pregnant women. If I got you well, if we have a pregnant woman in a community that is at risk, and you plan to vaccinate this community, and we know that vaccines are not safe for the pregnant women, how are you going to help this woman who is at risk to be protected in such a community? I submit.
Okay, then Maddy. Unfortunately, we can't hear you, Maddy. Maybe you get closer to your microphone.
So yes, I was saying thank you so much, Dr. Chobe, for the very informative discussion. So my concern is about the level of community awareness. From your presentation, I've seen that the major mode of communication that we are using currently is through social media, but we realize that our population, a very small percentage really uses social media. Of course, you consider key areas like Kampala, where social media, of course, is very much utilized. But I believe in our setting, especially in the hospitals, I've not yet seen IEC material, for example, to keep the public really aware. I feel like we are still lacking in terms of the level of community awareness. So I don't know what plans the ministry has in regards to that. Then the other thing is concerning training, especially of the healthcare personnel. I feel like we've not yet really focused on that. We need to also engage healthcare personnel in private practice. I don't know what plans we have for that, because as we see our first case, we have a number of private healthcare facilities that were from where we got contacts. So I don't know what plans we have in regards to that. And I request the ministry perhaps to look into all that.
Thank you so much for that question. Members, we have about 10 minutes. Sorry, I temporarily fallen off, but I'm back. Benjamin, there are other quick comments and questions on the chat room. I would think that the rest of the questions can be sent there. There are quite a number of questions already. I would think the next few minutes left we will give to Dr. Henry to respond to those questions that have been raised to him. Dr. Henry, over to you.
Yeah, Mr. Moderator, I'm seeing a colleague of ours, Juma Nyakina, who is a Maodo friend, I think is from Kagera region. If it pleases you and you can permit him to ask his question. He's from Kagera, Tanzania. Juma
Please
Nyakina.
let him go ahead.
Thank you very much, Dr. Chove Bosa. I'm very glad to see you after so many years and presenting this very important matter now here. You are in Uganda and I am here in Bukoba, Kagera. So this is just a mouth nose distance. So we are very close. My first question, I think you are going to read it. I did put it in the chat. So my second question is, I just want to know, do you have any plan in place, if any, that you probably make sure that you keep monitoring the survivors, because we are not sure then maybe one clinically can be okay and discharged, but still having the virus in the body circulating. So for how long do you keep monitoring an individual who has survived the infection? Then the second question goes to not necessarily you, doctor, but could go to my colleague from Busoga or even Dr. Yai. I just want to know the practice of IPC. how have you there in Uganda, particularly in the areas that are under observation now, how have you institutionalized the practice of IPC, or is still left to remain just optional and the individual's responsibility, or is supervised by the facility administration? Thank you very much.
Thank you for that question. Maybe Dr. Henry, just one from me.
Yes.
I've had questions from members of the public, whether it is still safe to go to church or to go to any public gatherings in this era. And I think we have to speak to the public about this as well. Thank you so much, members, for the questions. Sorry,
Yes,
go ahead, please.
I need to start with that we have no restrictions to going to church, and we think the level of exposure there is low, if any, neither for public gathering. That advisory has not been given. So churches, mosques, and areas of worship remain open, and we are only advising remain alert. It's only when you identify somebody with those overt symptoms that I will speak about, that colleagues have asked about, that you need to report to us or to report to those numbers that I've shown you. Source of the outbreak, in one of my starting slides, I indicated that we are working and moving backwards as far back as 3 months to see the likely source of exposure. The colleagues say that has been in many places they have found this source. Maybe that is not precisely accurate, even where they have potentially thought they have found, it remains largely circumstantial. But we have indications. It's for Marburg that way usually, I know in Kamweng, we're able to pinpoint where the exposure was, but this is not done. But efforts are ongoing to find the most proximal, and that's the word I use, the most proximal case to the transition from the wild to the humans, and that work is ongoing. But as that is ongoing, the key thing and the most important thing right now is to ensure that we control transmission. And the question on whether individuals had crossed the border, I indicated to you in the period we think the individual was exposed, I was able to give you a high resolution geopositioning of this individual for that period. There's no evidence whatsoever that he traveled out of the country. Neither is there any evidence that he traveled in that period out of Kampala and Wakiso in that period that we think he was exposed. A colleague asked a question which is very, very important. The unspecific symptoms of Ebola, mainly at the start. And I want to say that we have to be very frugal and be very cautious so that we don't miss Ebola patients, but at the same time, we don't deny patients due care that they need. Yes, the most dramatic symptoms actually manifest late, much later. Usually day 1, day 2, day 3, they are mild symptoms, non-specific. Fever, which usually doesn't come down, and in the area of 38 degrees and above, headache, then later on you start having vomiting, diarrhea, starting usually with nausea, and later on you start having hemorrhagic manifestations. Yes, it's a very thin line, but in the current circumstances, but we also know, as we saw in Mubende, that we had individuals, and that's why we kind of lost a bit of time in detecting that outbreak, that some individuals had malaria Ebola co-infection. So you need to take a note of this potential malaria Ebola co-infection. But again, we need to be able to identify these patients. One of the other things that you need to look at, clustering at household, clustering in the community, and potentially death. I don't like to talk about death in these circumstances and clustered death because these are usually late signals when things have actually happened. But what happens, as we know now, that we have a rapid turnaround time of results. If we screen these individuals, meeting the case definition, we have a sample run to us, we can quickly run it, and of course, reclassify this individual. Please take note, when we have these individuals, usually in the early phase, if they have been detected or suspected, we run 2 samples, an early sample and a repeat sample after 72 hours. Because early samples, there's a likelihood of low viremia, which some platforms may not pick. So we argue that we get a second sample after 48 to 72 hours to ensure that we were not late. Question on vaccines, whether they are available. Yes, we have some J and J vaccines, but also have trial vaccines. Trial vaccines are specifically for contacts. For the rest of the others, we have the J and J vaccine, but they are minimal doses, by the way, not a lot. Minimal doses. And of course, for now, we are prioritizing health workers. But that vaccine, if you have it, the J and J, as I indicated earlier, that the protection comes much later. But for the trial vaccine, as I said, for contacts, those who are consenting, we have an early arm that is immediate, then a late arm after 21 days, meaning that all contacts, either an early arm or late arm, will be vaccinated. Now, the question from a colleague from the media about the genomic sequencing, let me use the common language that you have brothers and sisters. So brothers, sisters, and cousins. So we would say it's the same virus, but it is a sister to one of Ruero in 2022, and potentially a cousin to one of Mubende. The importance of this is that Mubende, because it is persistent sometimes among survivors, and I'll speak to that because the question came through, that we think in our view that this vaccine, that this outbreak is not a continuation of the Mubende outbreak. And we think it's a fresh spillover event from the wild, from the zoonotic reservoir. Yes, the update from the ministry, one, we're not hiding anything, and I've spoken anything that there is to say here, including telling you where patients are, and of course, the things we have done. I think, well, it is good to give numbers, and why we personally accepted to speak to this forum is that the questions, the things that people need to hear. People asking about the private facilities, what should we do? Going to church, should I go to church or not go to church? How do I sanitize? Are pregnant women supposed to be vaccinated? How do you pass on information? Did the virus come from Zaire or from Sudan? To us, those are the most important things. And the colleagues in the media appreciate that the duty we have to the population is to give those pieces of information they need to use to protect themselves, number one. Then in number two, to be able to report early and for us to be able to get the population aware. Yes, it's true. The guidance that you got, the updates will come every 2 weeks, and that's a fact. It is a slight deviation from what we did in the past, but things are not static, and we don't do things in the same way as usual, as you know. And indeed, we are not hiding anything, and take that from us. We are not hiding anything. We are sharing information as much as possible. And whenever we have a confirmed case, the response teams are informed The respective people are informed, and of course, we use this information for a response. But then the update comes after 2 weeks, as you heard from the Honorable Minister. Why? It is a decision, and gives us time to concentrate and give information on the things that the population need. The information package, the DG talked about, this will be deployed soon. We hope in the next week. Colleagues, remember, it is just a week since the outbreak was declared, and a lot, as you may have seen above, has been done, but not that everything is being completed this period. But of course, this package will come through and will be deployed in different ways, either physically or electronically, where colleagues can be reached by different colleagues at different areas. Information sharing on different spaces, WhatsApp, and I'll combine this with a colleague, lady colleague, who asked about the social media and the rural settings, which use different platforms. We use different platforms, colleagues, and not WhatsApp, not only Twitter, but also we have radio shows, we have, what do you call them? Film vans, depending on where we deliver this message. But the key message, as I said, is notify whoever has symptoms. Number 2, report early. And if somebody is exposed, let us know so that we can decontaminate your setting and, of course, have the individuals one. So I want to demystify a point. These diseases took names from countries where they were identified, Zaire and Sudan. And where this Sudan virus was identified, it's no longer even in Sudan, it's now South Sudan. And whether there is a risk of spillover from Congo or anywhere, it will remain on high alert at all times to detect this. But this shouldn't, because now we think that the current outbreak didn't even come from Sudan. The virus came from the wild within our country. So the question on what the private facilities need to do, the question, be alert. Be alert. Be alert. Don't in any way, don't in any way try in any way to manage Ebola. It is bad for you. It is bad for the staff you work with, and it's bad for the patients, and it's really bad for the family. Reason is that identify, notify us, we'll come, assess this, and after assessing, we should be able to classify or reclassify these individuals. And if need be, it will be us to help you decontaminate your setting, not you. And then to guide you on further actions to take in that facility before it is reused when a case is suspected. Yes, pregnant women are eligible for vaccination, but they may choose to opt out. But even when they opt out, again, there are other public health measures and, of course, clinical measures in case they get infected. Training of health workers. When you sit where we sit at the beginning, there are things you get out of the way, and then subsequently you get those activities that you need to do to make sure that you roll out. This week, we have 72-hour activities. We have 7-day activities. And again, we have 30-day activities. So there's a sequencing of these activities along the way. And we make sure that we do that. So the training of health workers in different facilities on IPC, very important, which starts obviously with assessment of IPC, noticing the gaps, and of course finding ways of fixing them, and of course defining the needs, and again, of course, the other aspects. My brother Juma Nyakina, I went to school with him many years ago. somewhere, and good question. Survivors, certainly we have a survivors program, which includes, among others, psychosocial therapy, management of post-acute phase sequelae. Number two, on male survivors who usually have virus persistence in semen, and of course the measures that we advise them to do during the period of follow-up until when the semen becomes a viremic, which of course spans usually several weeks. On IPC, to be whether it is a practice is institutionalized, yes, it is institutionalized, but it's an area which is emerging and growing in this country, but we are there. But certainly in this country, there's a great variation in IPC practices from facility to facilities, and that we are trying to bridge. Thank you so much, and over to you, Dr. Yai.
All right. Thank you so much, Dr. Henry, for responding to the issues. Members, probably if your question has not been responded to, especially in the chat, I think you can be able to follow with our technical teams and you will be supported. But at this point in time, I want to take this chance to thank you so much, Colonel Dr. Henry Chobe Bosa, the National Incident Commander, for giving us time to speak to us and also speak to the questions that members have asked. And I want to thank our hosts, Busoga Health Forum, for bringing us together. The technical teams are on ground. They are doing work. We urge the members of public and any others to be able to continuously engage us on these matters so that information is seamlessly accessible and we get guided. In the interest of time, I want to hand us over to my co-host, Benjamin of Busoga Health Forum, for closing statements.
Yeah,
Thank you so much.
Thank you so much, Dr. Ais. Thank you, Colonel Dr. Chove. And at this time, I just want to call Professor Peter Chove, the board chair of BHF, to give closing remarks. Over to Professor Peter Chove.
You mean Professor Waiswa?
Is Professor Peter Waiswa is unmuting.
Thank you so much, Dr. Yai. This is Moses, the CEO of Busoga Health Forum. We want to thank you and the Colonel and the Minister of Health for giving attention to this important issue. We thought Prof. Peter would be able to address, but I think could be far from his phone. So we want to take this opportunity to really appreciate you and want to say that we shall keep coming to you, Colonel Chove, for this kind of talks and guidance to the forum. The forum is here for you to disseminate these important messages to people and always reach out for further guidance. So we'd like to take this opportunity to hand over a few accolades from our side as a symbol of appreciation and as per our culture as the Busoga Health Forum. We want to thank you so much, Colonel Chove, for presenting at the Busoga Health Forum, and we want to take the opportunity to hand over this particular certificate to, first of all, Dr. Alfred Yai for providing leadership during this presentation, but also to thank you as the Busoga region for the services you offer. Thank you so much. We award you this certificate, and we thank you. We invite you again to support Busoga. And to our brother, Colonel Dr. Henry Chove, we thank you so much for always being ready, commanding at the right time, and coming out to support the Busoga Health Forum, but also the country at large. We want to extend this certificate of appreciation to you for your commitment, the research you make, and all that you prepare for us. The whole world has been listening to you, and everyone was struggling to join this call to listen to you. You don't know how many calls we received today because people had seen a flyer with your name, trying to confirm whether it is true you are coming. So it is a pleasure, the entire region, the entire country. We appreciate this kind of support. May God bless you so much for this wonderful achievement you have given to our forum. And the rest of the members want to thank you. Maybe want to invite the Director General to give a closing words so that his brother, Professor Waiswa, will take advantage to listen from the DG. So our DG, please over to you to give the closing remarks.
Prof, it appears DG left for another meeting. It's a bit of a lot of work here. And even right now, we are still working. So I'm not sure if he kept on, but I think he has joined another meeting in another boardroom.
And for that matter, we invite you, Kano Chove, to give closing remarks to this important meeting. Thank you so much. Over to you, Kano Dr. Chove.
There's no way I can thank my colleagues with Soga Health Forum for the initiative. This morning I was talking to a couple of colleagues, and then gentlemen and ladies from the East are usually the wise men, and for crafting this. And for us here, we took it as an advantage in the ministry to make sure that we speak to you, colleagues, health workers, and of course other people. And as you've learned, as you rightly say, that people from all over the world and different places, but more importantly, Ugandans, so that they get the right information, protect themselves, protect their families, and be able to deal with this. We can do it. We've done it before, and we shall do it. And we wish that with your cooperation, with your support, we'll do whatever is possible. There could be some inconveniences that will come along the way. We request, bear with them. Those that you see at the airport, some individuals, again, if you're exposed, becomes easier for us to follow you. Thus, we need to quarantine you. Some facilities, we may change activities and some inconvenience, but bear with us on this. Is that DG? Bear with us. Bear with us. We should be able to end this together as fast as possible because we have done it before and we shall do it. To my colleagues in Busoga Forum, there's no way I can thank you so much for the certificate, and I really appreciate. And call me again, but not on other things. Should be the kinds of things that I know, and I think I should also be part of Busoga Forum going forward. I thank you so much, and over to you, Prof. Waiso.
we may not be able to have Professor Oiswa. He is sent in a project. He says he can't speak where he is right now, but he was grateful of the whole presentation. He has been listening in. Thank you so much, members, for joining this call. These sessions happen every Friday, 8 to 9 p.m. We have CME, so we invite you next Friday to join in. Thank you so much, Doctor. I can't thank you enough. This has been so insightful, and thank you to the entire team. There's been a production team behind the cameras of Dr. Chobe. That has been a great team. Thank you so much. I'm really humbled for everyone who has made sure this CME becomes a success. Have a good night, enjoy the weekend, and make sure you take the precautions just as we have learned of them today. Thank you, team.